Good evening, everyone present here. I am Faraz from IGCP. Welcome all the dedicated group of healthcare professionals and advocates gathered here for today's important discussion, CME. Like we are meeting to discuss the mission of critical national importance, that is Anemia Mukta pregnancy. While we are having robust frameworks and public health initiative in place, the reality on the ground often tells a different story. Today, we are focusing on bridging the policy practice gap, and our goal is to move beyond the paperwork and explore how we can ensure the every expectant mother actually receives the nutrition support and clinical interventions she needs for a healthy, vibrant pregnancy. As we know that this topic is important, so I would like to invite the moderator for this session. She is none other than Dr. Dipti Nab, ma'am. And let me share some of the achievement of ma'am. Ma'am is a senior consultant at Mother and Child Clinic, Krishna Nagar, Delhi, and she is present Delhi Gynecological Forum East president, and she is very passionate about the Anemia Mukt Bharat, and for that only, like all the panelists today came are they all are passionate to make this Bharat free from anemia. And like for with this, I would like to invite ma'am and hand over this session to ma'am to introduce rest of the speaker and panelists. Over to you, ma'am. You can proceed from here.
Thank you, Faraz. Good evening, dear friends and respected seniors. Today is a very important topic we are going to talk about anemia mukt pregnancy, bridging the policy practice gap. India has some of the world's largest policies: Anemia Mukt Bharat, Poshan Abhiyan, routine HP testing, universal iron supplementation, IV iron availability. We have very clear cut FOXY guidelines and Ministry of Health and Welfare guidelines. Yet, more than 50% of our pregnant women remain anemic. So, the real question is, where are we losing them? Is it a knowledge gap? Is it a policy gap? Or is it a practice gap? It is not just giving iron tablets to the pregnant women. It's about the early diagnosis, right iron, right route, right time, counseling that works, systems that track, and clinicians who act before anemia becomes an emergency. And to make these things crystal clear, it is an honor and always sheer happiness to introduce. She doesn't need any introduction, yet it is an honor to introduce our beloved teacher, Dr. Sharda Jain ma'am. She's the Director, Life Care Center and Life Care IVF. She is an expert ethical committee member of NMC. She's the Secretary General of Delhi Gynae Forum and founder and chairperson of North India Gynecological Forum. Welcome, ma'am, and over to you.
Thank you, Dr. Deepti Naab, and I think together we are going to doing a great job. It will be pleasure that you introduce your experts also before I take up.
Fine. We have amongst us experts, Dr. Taru Chaya. She is Senior Consultant OBGY, Bansal Hospital, Jaipur. Madam is Secretary Narchi, Rajasthan, Vice President NIGF, Past Secretary JOGS, that is Jaipur Ops and Gynae Society, co-convener of AMWI Jaipur. Then we have none other than welcome, Dr. Taru. We have Dr. Leena Sridhar. Madam is Chairperson and HOD of OBS and Gynae Academics and Research, Manipal Hospitals. Welcome, Dr. Leena. We have Dr. Nishi Makhija. She's Senior Consultant at Tirtharam Shah Hospital and also the President of Delhi Gynae Forum East Civil Lines. Welcome all the experts, and over to you, Sharda ma'am.
So thank you, Dr. Deepti, and all our experts. I'm going to make a very take a very important topic, anemia mukt Bharat, and especially focus on pregnancy. But at the same time, I will take to a newer treatment modality, and we would like to have your experts' opinion at the end of it. One thing is very clear. Today, India stands contributing 40% of the total anemia cases in the world. We aim to have anemia rate of 5%. At the present, on an average, we have 50%, more than 50% people have anemia, and I'm going to dilate on this. Big aim, big focus, but I'm sure all of us put their mind together, we should be able to do this. So with that, I'll just share things. Can you see my slides?
Yes, ma'am.
Yes.
So, coming to anemia of pregnancy, it's a call to action from policy to practice. As you can see, the global map, anemia is a big curse as far as our country is concerned. We are having this particular problem of anemia in women from centuries. And anemic Indians make 40% of the global anemia burden. I'm talking in 2026, and according to WHO, there are 1.92 billion anemic cases globally. And India contributes 40% to this global burden. 67 to 70% of its children are anemic up to less than under 5. 60% of adolescent girls are anemic. 57% of non-pregnant women aged between 15 to 49 are anemic. 52% pregnant women are anemic. And 60% women who are 50 plus are anemic. 25% of men and 30% of boys are anemic. And this is according to National Family Health Survey 5. Now, what is our aim? The government of India aims that in Viksit Bharat, the anemia rate of our girls and a woman will be less than 5%, just like any other developed countries. Every girl and a woman will have hemoglobin of 12 gram percent or more between 10 years onwards. Now, some of us are not very clear about the cutoffs, and the people who are hearing me on this particular platform, I wish to make it clear again. As for the pregnancy is concerned, the government of India, first trimester, second trimester, third trimester, anemia is any time when the hemoglobin is less than 11 gram percent. WHO also says the same cutoff is there of 11 gram percent. As far as non-pregnant state is concerned, WHO classifies again the hemoglobin should be 12 and 12 plus. Mild anemia is between 11 to 12, and moderate is between 8 to less than 11, and severe is 8. While in pregnant woman, it is anybody less than 11 is mild, anybody less than 10 is moderate, and anybody less than 7 gram percent is severe. So between non-pregnant and pregnant and severe anemia, the cutoff for pregnancy is 7, while cutoff is 8 for non-pregnant people. Now coming to postpartum anemia. WHO says that, any hemoglobin in a postpartum period less than 10 is postpartum anemia, and anything less than 7 is severe anemia. FIGO says that anything less than 11 in a postpartum period is anemia. And as far the India figures are concerned, it takes 11 gram percent at the end of 1 week postpartum, and at the end of 8 weeks, it is 12 gram percent. So, having been clear of the cutoffs, why iron deficiency anemia and pregnancy is a national emergency by experts and the government of India? The hard facts which stand out in January 2026 is that 52% pregnant women are anemic according to the National Family Health Survey 5. It contributes to increased maternal mortality. I will come to actual figures. It increases PPH, preterm birth, low birth weight, and stillbirths. Anemia is responsible for 8% of our direct maternal deaths, but in 22% additionally, it is responsible for indirect maternal deaths. So any of the complications, if they combined with anemia, this is a bad combination. And in total, we lose 30% of women which are directly or indirectly related to anemia. Uncorrected anemia leads to intergenerational anemia. It means anemic mothers make anemic babies who are low birth weight. They become anemic adolescent, and when they are anemic adolescent, if it does not get corrected, they become anemic mothers. So this intergenerational cycles goes on and on and on. We have not been able to put a break in the last 1 century. Government of India stand is Anemia is not nutritional issue alone. It is a maternal survival issue. The work on anemia has been going on since the time we got independence, but Prime Minister himself is leading it from the front from 2081 2018 2018 से वो इसको लीड कर रहे हैं पोषण अभियान as well as anemia मुक्त भारत अभियान. There are 6 strategies, 6 interventions, and the 6 people category of people who have to answer it. We got to reduce anemia by 3% per year. It should reflect on National Family Health Survey. But as we can see here, that it was going very well. But National Family Health Survey 5 shows that we are off the track already. Testing hemoglobin and timely treatment is mandatory as far as government is concerned. Prophylactic supplementation, if the hemoglobin is more than 12 gram percent, also all girls and a woman should take weekly iron folic acid supplementation because anemia can strike anytime. Dietary diversification is very important to see that you prevent anemia. Deworming twice a year. WHO recommends any age, any sex. People should be deworm themselves twice a year in India if they are staying. Behavior change communication is very important, that it should go and rub in the mind of the people that the big target is 12 gram percent and everybody should say that I will be 12 gram percent and more. That should be our aim. Achieve hemoglobin of 12 or more before pregnancy, that's our aim. And it should be 11 by 28 weeks, 11 gram percent by 28 weeks. And many key opinion leaders like me and Dr. Manjupuri says that it should be 12 all the time during pregnancy as well. Now, what are we doing? During pregnancy, we are doing hemogram with all indices, and we also screen our patients for hemoglobinopathy, especially thalassemia. The clinical management protocol of the Government of India recommendation is at booking get the CBC and peripheral blood smear, also get hemoglobin electrophoresis to exclude thalassemia. Short of this test, to exclude thalassemia becomes very difficult, and it is system loss and the treatment loss that we have a birth of thalassemia major child. We got to repeat hemoglobin 2-3 times subsequently, once at 14 to 16 weeks, then between 24 to 28 weeks, and then close to delivery, around 32 to 34 weeks, you must get a hemoglobin level done, and a correction should be made and aim at hemoglobin of no less than 11 gram percent, but aim at 12. Now, these are the key Government of India interventions that universal iron folic acid, and I repeat again, 100 milligram of elemental iron plus 500 microgram of folic acid daily for 180 days, even if the hemoglobin is 12 gram percent or more. So even if you are not anemic, you got to take iron folic acid supplementation because the need of the child are added on to the needs of the mother. IV iron, that is either ferric carboxymaltose or sucrose in case if the hemoglobin is less than 10 gram percent. It is recommended for faster hemoglobin rise, better compliance, and a fewer GI side effects. Deworming, as I already said, that albendazole 400 milligrams single dose is recommended during pregnancy after 14 weeks. Nutritional focus has to be especially emphasized, that she has to take iron, folic acid, protein, and when they're taking it, vitamin C has to be added on for good iron absorption. Calcium and iron should not be taken together, and it is desirable that no tea or coffee is taken after meals, which is a bad habit found in Indians lately. Now, as for the clinical management protocol of the Government of India recommendations is that must achieve a hemoglobin of 11 gram percent. First trimester, second trimester, third trimester. Prophylactic iron folic acid has to be taken even if your hemoglobin is 12 or 12 plus. If there's a mild anemia, 2 oral iron folic acid tablets have to be taken, which is 100 milligram iron is there. They should be taken together and not morning and evening. If the hemoglobin drops below 11 gram percent. Moderate anemia, daily you should do a trial, therapeutic trial for 2 tablets of iron folic acid plus recommendation of a good diet. Uh, and in case if the hemoglobin does not rise to 1 gram at the end of 3 to 4 weeks, then you have to switch over to iron, IV iron, if the hemoglobin persists more than 10, less than 10 gram percent. Severe anemia is classified as any hemoglobin is 7 or less. IV iron plus blood transfusion is required as an institutional care. It cannot be done on the OPD basis. Parenteral iron preferred in second and third trimester for a moderate anemia. Because in case if the moderate anemia does not get corrected, patient will land up in severe anemia because the baby takes the need of its development from the mother, and the mother of moderate anemia who is not treated will land up in severe anemia. And it is the severe anemia which kills the mother as well as the baby. These are FOXY GCPR guidelines. Parenteral iron can be alternative to mild to moderate anemia in pregnancy who are not compliant or who are intolerant to oral iron. This is grade A recommendations. Parenteral iron is also recommended for pregnant women with severe anemia who are hemodynamically stable and require rapid restoration of iron stores in the second and the third trimester of pregnancy. Again, grade A recommendations. High quality studies evaluating the safety and the efficacy of the ferric carboxymaltase in anemic pregnant women should be performed. It is grade A recommendation. And of the various parenteral iron preparations, iron carboxymaltose is preferred for use in pregnancy. Again, grade A recommendations. Now, in postpartum administration, parenteral intravenous may be preferred alternative over oral iron for ensuring compliance and a faster response in a postpartum period. Otherwise, it is recommended that iron folic acid tablet, 1 tablet, should be taken for 6 months and not to be stopped. Ferric carboxymaltose has an advantage of administration as a bolus dose in a postpartum period for correction of anemia and the restoration of iron stores, because the ladies get so absorbed in baby's care that they forget to take iron folic acid tablets as well as the calcium supplementation, which is to be taken at least 1 gram for 6 months. Now, you can see here that if IV iron is given to correct moderate anemia, both the maternal and fetal outcome are good. It is seen that 25% incidence reduction of low birth weight is there, and nearly 75% women achieve non-anemic state of non-anemic state, that is, their hemoglobin is more than 11 gram percent. So it is a rapid iron which is important. Are all FCM same? I will say no. I'm not here to spell out which iron is better and which iron is not better. Your experience will show which one is better or not. Now, to call to action from policy to practice. Government expects from doctors that you treat anemia as a medical emergency and not as lab abnormality. It's a medical emergency as far the country is concerned and the safety and the mother's child is concerned in the pregnancy. Shift from tablet-only approach to timely IV iron to break the intergenerational anemia cycle, especially seeing it that the moderate anemia gets treated. Ensure hemoglobin correction to 11 gram percent before labor. I'm fond of it that it should be made 12 gram percent at the time of delivery. Now, government policy and the message is very loud and clear. Hemoglobin should be tested initially. It is not negotiable. Record the management, treat, and then repeat hemoglobin again whether the response has been good. Anemia-free pregnancy amounts to safe mother, safe baby, and thereby strong Bharat. Correct anemia before delivery and not after the PPH has occurred. So the golden wisdom tips on Anaemia Mukta Bharat is treat anemia first. It's the first priority. Treat anemia fast. These are two things. Anemia must be treated is a priority, and treat anemia fast. Now you can see here on the left hand picture shows that our aim is the best, that is hemoglobin of 12 and 12 gram percent. And I said anemia correction has to be fast. So by mid trimester, the hemoglobin should be not less than 11 gram percent. So anemia Mukt Bharat fast and first. Now let's recap what all I've said. This repetition is good for all of you. Now, this is a National Family Health Survey. You could see it from 2006 to 2016. There was the decrease was expected was 3% every year. This was not satisfactory. But when the National Family Health Survey 5 came, you could see the incidence of anemia increased in every group, whether they were children, whether they were adolescent girls, whether it was pregnancy, non-pregnant state, or the senior citizen. In every category, there was a hemoglobin was on rise. That shows that we were already derailed from our task. The burden and the reality is anemia and pregnancy in India has reduced only marginally in 10 years. That is, it's National Family Health Survey 3 and 4. This progress is unacceptably slow, not acceptable. 5 shows that the anemia has increased, not decreased compared to survey 4. And as I said, only a single digit reduction in anemia over last 10 years in India, and now an increase in trend seen in the National Family Health Survey 4 to 5 is not acceptable. Anemia is not a mild hemoglobin deficiency, but a major public health emergency. Even mild anemia saps away energy from your system. Maternal anemia contributes to 80%, 18%, 18 to 20% of the perinatal deaths. Remember, it is severe anemia which kills the mother as well as the baby. So the moderate anemia must be treated first and fast. So the severe anemia you don't face. Maternal anemia contributes responsible for 20% of maternal deaths in Southeast Asia and 30% in Bharat. It is 8% direct deaths and 22% are indirect maternal deaths because of anemia. Now coming to maternal and obstetric health. As you can see here, 8% is direct deaths and 22% indirect deaths as far as the anemia is concerned. Anemia silently worsens outcomes even when pregnancy appears normal. Moderate anemia causes harm long before severe anemia appears. Anemia fuels the cycle of low birth weight and IUGR. An intergenerational anemia cycle gets started, which we have not been able to fix in the last 1 century. The consequence of anemia and pregnancy are that there's an increased preterm delivery, there's a premature rupture of membranes, there's increased preeclampsia, IUDs, intercurrent infection, antepartum hemorrhage, and congestive heart failure in severe variety. As for the fetal outcome is concerned, low birth weight, prematurity, infections, neonatal anemia, abnormal cognitive development, and increased risk of schizophrenia is seen in the babies. Now, this particular slide shows it further. Maternal anemia may result in abnormal hematological parameters in the neonate. Neonatal anthropotic changes also are noted. These children are stented and they have a less weight. Impact of anemia on the fetus neurodevelopment is also seen. And they are now getting related to intellectual disability, autism spectrum disorders, attention deficit, and hyperactivity disorders. Increased risk of cardiovascular diseases in offspring, and a possible risk on renal system, thyroid functions, and immune systems. So not only pediatricians are worried, whole of country is worried because of the implications on the neonate. Screening and diagnosis. No NC checkup, no hemoglobin in the first trimester is not negotiable in present day. Repeat hemoglobin testing 2 to 3 times is essential, and hemoglobin of 12 gram percent at delivery must be aimed because an anemia can develop or worsen rapidly anytime. Do not wait for symptoms. Anemia is often clinically silent. Moderate anemia deserves active correction by IV iron, not reassurance. Remember, moderate anemia, when it goes to severe anemia, kills the mother as well as the baby. Pregnancy increases iron requirement beyond what diet alone can supply, plus iron folic acid. Delayed correction leads to poor fetal growth and the bad birth outcomes. Treatment philosophy is oral iron alone is often too slow in pregnancy. Poor compliance is common with oral iron due to side effects. 5 minutes counseling is must. When to take iron? It is preferred that they should take it empty stomach or within 1 hour after taking a meal. All iron tablets should be taken together and not morning, afternoon, and evening. This particular slide is again given by the government of India shows kya khaएं और kya na khaएं. This shows that iron folic acid tablet has to be taken in time. Preferably, it should be taken with lemon water. Green leafy vegetables are a great source of iron. Same is meat and other non-vegetarian preparations. Vitamin C and rich fruits should always be combined in your diet, and especially during the meal. Sprouted pulses are very good. Now, there are some don'ts. Tea and coffee after the meal should not be taken. And on the right hand side, it shows that the calcium and iron tablets should not be taken together. And from time to time, hemoglobin is repeated, and the doctor says that you are not deteriorating and you are complying as far the treatment is concerned. I again repeat that there are plenty to eat. You should take vitamin C rich food, sprouted lentils, uh, vegetables, tomatoes, lemon, amla, and all these citrus fruits. Tea and coffee, again, I'm reminding to everybody who's listening me, you are in the habit of taking tea and coffee after meal, please stop it. No chips, cola, drinks, and cigarette and alcohol, big no, no. This country today, we are lucky that we have everything available. We are, as far food is concerned, we are surplus and we are exporting it outside for the other countries as well. So the moderate iron deficiency anemia requires effective protective outcome and the fast correction with IV iron. Timely correction with IV iron improves both maternal reserves and the fetal outcomes. Experts feel that in case of pregnancy, anemia will go with 100 grams of IV iron. One-time correction improves compliance better than multiple doses. So I think all clinicians who are listening me should listen to this one-time correction with FCM. Treat anemia as medical emergency, not a routine supplement issue. Get obsessed with hemoglobin of 12 gram percent in all trimesters. Role of IV iron, that is FCM. Single dose of IV iron is game changer in pregnancy, both in correction of anemia and for better fetal outcome. Calculation of parental iron requirement, you all know Gonzoni's equation. 2.4 multiplied by pre-pregnancy weight in kg and the hemoglobin deficit, and then you add 1000 milligram for storage and 500 milligram in a non-pregnant state and 1000 milligram in a pregnant state. So rest second and third are also alternative, but the commonly which we use is the first one. Now, as far as the parenteral iron therapy monitoring is concerned, quite a few of the gynecologists are also scared about using it. They should give up inhibition. FCM infusion should be administered where the staff is trained to evaluate and manage anaphylactic reaction immediately. I repeat again, you should have things ready to evaluate and manage anaphylactic reaction immediately. There should be full resuscitation facilities must be ensured in the center where IV iron is being given. The patient should be observed for at least 30 minutes following each FCM infusion. One should not get scared. It's very easy. You should have only drugs for to meet anaphylactic reactions, and that is 1 cc of adrenaline has to be given by intramuscular injection. As far as treatment is concerned, that's a mainstay of treatment. Corticosteroids you can give, which will add on to 10% of the care when the main care is adrenaline injection. Ferric carboxymaltose allows high dose of iron in one sitting. That is, in 15 minutes time, you can give 1000 milligram. It is not associated with dextran-induced hypersensitivity, which is very common, and multiple doses like iron sucrose are not needed. FCM has a short infusion time, 15 minutes, 1000 milligram in 250 ml of saline can be given. Faster hemoglobin rise means faster protection of mother and the fetus. Single dose of IV iron improves treatment completion rates. IV iron avoids the gastrointestinal tolerance in comparison to the oral iron. Clinical decision making is treatment of moderate iron deficiency anemia should not be delayed till late pregnancy. Correcting anemia early reduces low birth weight and perinatal risk. IV iron is especially valuable in high risk pregnancies where low birth burden setting is all set. Clinical guidelines should be prioritize single dose IV iron. Treatment choice should be outcome driven and not cost driven. Quality of IV iron formulation matters for safety and efficacy. And not all FCM brands are clinically equivalent. Indian evidence and practice shows that quality and the safety differences among FCM products is there. Choosing a reliable FCM brand improves the clinical confidence. Effective anemia correction reduces maternal fatigue and improves labor tolerance, and she can fight out the consequences of PPH if it occurs. Moderate anemia correction is a IUGR and stillbirth prevention strategy. Anemia-free pregnancy is a foundational for safe motherhood in healthy India. Anemia in pregnancy is preventable, it is treatable, and life-saving if treated early, decisively, and correctly. Let's make India anemia-free. Rapid correction of hemoglobin to 12 gram percent is a lifesaver to tide over the complication of pregnancy to the mother as well as to the baby. So the journey is long. On an average, we are more than 50% people have hemoglobin less, and we are anemic in this country. And our aim is for Viksit Bharat, that is 2047, to bring down to less than 5%. Thank you. Thank you very much.
That was a wonderful talk, ma'am. And like you very rightly emphasized, that irrespective of the trimester, hemoglobin less than 12 is non-negotiable. If we keep this thought as the first and the foremost thought, I think very soon we'll be able to achieve our target of a single digit percentage of pregnant women are in fact Anaemia Mukta Bharat. Because we know that anemia is not a mild condition, it's life-threatening. The risk of PPH, infections, heart failure, preterm births, low birth weight, and maternal near-miss events. It actually undermines every effort we make towards achieving safe motherhood. And also, you've very clearly outlined its two effects. One is on the mother and then the fetus, the development delays, the perinatal mortality. So it becomes all the more our moral responsibility to see that every pregnant woman has a hemoglobin of 12. And I invite Dr. Taruchaya, ma'am, what is her opinion and that one counseling tip to improve the compliance of the patient, that how do you inculcate into them, their souls, the family soul, that hemoglobin should be 12. Dr. Taru.
डॉक्टर शारदा मैम, थैंक यू सो मच. एक्चुअली ये हमारा हो नारा कि हीमोग्लोबिन हो 12, इट्स वेरी इजी टू एक्सप्लेन टू पेशेंट्स कि भाई 12 होना बहुत ज़रूरी है, और उसके लिए प्री नेटल काउंसलिंग, पोस्ट इंटरवल काउंसलिंग एंड पोस्टपार्टम काउंसलिंग सभी इम्पॉर्टेंट है. हमारी एनीमिया इज इन प्रेगनेंसी वीकेंड्स not just the mother but the future of the country also. The Dr. Abul Kalam has said a healthy mother is the foundation of a healthy nation. तो इसीलिए हमारी सारी विमेन फीमेल्स को हमको ट्राई करना है डिलीवरी से पहले ही काउंसल करना है कि भाई तुम्हारे न्यूट्रिशन कैसे, वी कैन आस्क देम इफ दे कम टू यू, सो दैट ड्यूरिंग प्रेगनेंसी जो हीमोग्लोबिन ड्रॉप बिकॉज ऑफ फीटस होता है, बिकॉज ऑफ हमारी बॉडी मैच्योरेशन की वजह से होता है, तो आयरन एंड सप्लीमेंट के साथ साथ खाने पीने का ध्यान रखेंगे तो हेल्दी मदर रहेगी तो हेल्दी बेबी एंड आउटकम रहेगा ना. ये मेरा कहना है. मैम ने सब कुछ एक्सप्लेन किया है, लेकिन कितना आयरन हीमोग्लोबिन है उसका, कितना हमको प्रिपरेशन देना है, तो वो उस पर डिपेंड करेगा कि हमें ओरल देना है या आईवी देना है या कितनी बार देना है, कौन सा देना है. दैट विल डिपेंड ऑन पेशेंट टू पेशेंट.
यहाँ पे मैं कहूंगी कि हम जब 5 मिनट लगाएं ये बताने के लिए कि आपको ये सब दवाइयां मिलेंगी, ये दवाइयों की एफिकेसी उतनी ही अच्छी है जितनी कि आप बाजार से खरीद के दवा के लेते हैं. इनकी एफिकेसी उतनी ही अच्छी है और आपको ऐसे ऐसे लेना है. फास्टिंग लें या मील्स के बाद लें, आपको इसको विटामिन सी के जूस के साथ कुछ लेना है, ये सब चीजें आपको बतानी पड़ेगी. 5 मिनट अगर आप बात करेंगे तो मेरे को लगता है काम बन जाएगा.
जरूर. और मैम जो डिस्पेंसरी में मेडिसिन मिलती है दैट इक्वली गुड. जरूरी नहीं है कि हम उनसे कंपैरिजन करें कि बाजार की अच्छी होती है. तो मैं तो पेशेंट्स को ये भी कहती हूँ वो दवाइयाँ अगर आपको मिल सकती है प्लीज दवाई लो, वो भी आप खा सकते हो, उतनी ही अच्छी दवाइयाँ हैं चेक्ड. तो वो उनको कॉन्फिडेंस हो जाता है कि हाँ मैंने देखी है, तो वो फिर वो मेडिसिन भी ले सकते हैं. तो दे सेव मनी ऑल्सो एंड हीमोग्लोबिन तो डेवलप हो गई उनका. अच्छा,
वेरी राइटली सेड तारू मैम. डॉक्टर लीना, पॉलिसी हमारे पास है, पावर भी हमारे पास है, परंतु इम्प्लीमेंटेशन में कहाँ कमी आ रही है? आप बताएं दैट वन टिप that why are we hesitant to use IV iron preparation? So how can we make ourselves more robust in our attitude, in our approach to, it is us where we have that
It is
fear.
us.
Yes. So
It is us.
हम कैसे कर सकते हैं
Yes.
that more and more of us start using IV iron when we know that the hemoglobin is 10 and it's not going to work. It's not going to work because
Yeah,
she has
thanks.
the iron for so long.
Yeah.
And it is near term and we have to 12.
Yeah, thanks, Dr. Dipti, for the question. And wonderful talk as usual, Dr. Shada ma'am. And one line which you mentioned is anemia is preventable, treatable, and it is life-saving. That was actually that is the key word that I think we all have to remember. And when we were talking about Dr. APJ Abdul Kalam, I remember your words, and I use that in even a corporate setup where I am, that if you want your child to be like the APJ Abdul Kalam, then you have to make sure that you have a hemoglobin of 12. I think, that small such tips, send it across, because you find patients are very easygoing when it comes to saying, डॉक्टर साहब मेरा तो हीमोग्लोबिन 10 ही रहता है, मेरा तो कभी भी इससे ज्यादा हुआ नहीं है. So we don't have to allow that kind of compliance to come into our practice. And as senior gynecologists, we need to tell our youngsters, the junior colleagues, that do not accept hemoglobin less than 12. And what I want to just convey is that they should not feel scared about using IV, FCM injections. Very often I've seen, and I made sure I actually went and had to demonstrate, because we used to say that, okay, you have got to give it in 250, 1000 milligram, 250 ml of saline, and you must give it over 15 to 20 minutes. But invariably, I found that, they were hesitant because they felt kuch reaction ho jayega. So there was a delay in transfusing. And then when I had to explain to them that it becomes less effective if you do not give it at the correct time and at the correct rate, and do not be scared. What I can just say is that out of all the FCMs that we've had, we had only one case where there was a little bit of extravasation. So that is something we've got to make sure and teach our youngsters, our nurses, our junior colleagues that you should be very certain that you have it intravenous. There is no need to be scared. Keep your crash card ready, as it is in all the labor rooms. I think in all good labor rooms we have that. So we don't give it in the OPD, we give it in the labor room, to be sure that that small percentage of patient who may have a sensitivity reaction is taken care of. However, the drug is so effective, the drug is so safe, that I think we really don't need to be scared about it. So we've got to instill that confidence into our youngsters so that they use it. I think IV iron is the game changer. Apart from the diet, apart from the counseling that we all have to do, apart from that very simple tip कि नींबू लेना है, खाने में नींबू होना चाहिए ताकि all the iron in the food gets absorbed, proper diet counseling, deworming, and of course the proper, correct, and quick timing of using intravenous iron will ensure that our patients, by the time they reach the delivery table, they are 12 grams.
Good.
Absolutely
So
true, ma'am.
this is my,
Yes, very
this is
rightly
what
said.
I am following after all the so many Anemia Mukt Bharat programs we've had, thanks to madam's insistence. I think we are all taking it down to our junior colleagues.
Yes, and I think it is us as role models who can imbibe into our juniors and the staff. Basically, it is the staff who's hesitant to use IV iron. They are the ones, so they have to be taught to
Yeah,
be trained. They are the ones because they are the ones who are using it. So our focus has to be on
exactly,
focus on them.
exactly.
मैम आप कुछ कहेंगी डॉक्टर शारदा
Uh,
मैम
Then Dr. Nishi Makhija is going to say, because she is also again pioneer as far as the treatment of Anemia Mukt Bharat is concerned, and they have made a great changes as far as Tirath Ram Hospital is concerned. Dr. Makhija.
Dr. Nishi,
Thank you,
just
ma'am.
start with your comment. Ma'am has said that irrespective of the hemoglobin, to deworm our patients after 14 weeks of pregnancy. It's an excellent tip. So, आप भी एक हमें एक tip बताएं, which is all of us carry back home, how to make our pregnant women anemia mukt.
Okay. What I want to say is one thing is very important, that we have to make them hemoglobin 12 before they get pregnant. So we have to reach out into the society. We have to reach out to our young girls. And for this, at Tirath Ram, we are doing an adolescent project in which we go out to Delhi University colleges and we give talks on anemia, thalassemia, besides that PCOD, menstrual hygiene, etc. Because we really want to catch them young. Before they get pregnant, they should know about their anemia status, their blood group, their thalassemia status, so that they are aware of this. Because if we build up hemoglobin at that stage, then they will not come into, when they get pregnant, they will not be anemic. They will be well aware of the situation and they will get treatment before they go in for pregnancy. So that is very important. And second thing I want to say is, like in our hospital, what we have made a stamp for all ANC patients. When we advise iron and calcium, we put that stamp and tell them iron kaise lena hai, before meal or 1 hour after meal, along with lime water, not to take tea, coffee along with it, iron, calcium इकट्ठा नहीं लेना. Everything is there in the stamp, so that every patient carries that stamp, मतलब stamp जो लगी होती है उसके पर्चे पे, so that they are aware of it. So if we make clear these things, iron absorption also will be better, and whatever they are taking, at least they will be benefited from it. और बाकी थर्ड थिंग आई वांट टू से इज कि वी एज क्लिनिशियंस शुड गो आउट इनटू सोसाइटी, जैसे हम कर रहे हैं मैम, आपके पूरे एडवाइस आप करते हैं, हमें आप एनकरेज करते हैं, बिकॉज गोइंग आउट इनटू सोसाइटी, एनकरेजिंग ऑल पब्लिक, मतलब यंग गर्ल्स एंड यंग मदर्स and even non-pregnant females, as well as training our frontline workers, our juniors, our nurses, our ASHA workers,
Yes,
so
yes,
that they
we
are the
we
ones who actually go into society.
Doctor, we are all aware about it, that contribution of your institution and close by institutions to Delhi University, and a lot of knowledge has been given to Delhi University people for a hemoglobin of 12 gram percent, and you can see the wave in our country, that TFR Delhi is 1.2 in comparison to 1.9 as per the whole country is concerned. And this is the contribution of your people in Delhi University is commendable, appreciable, and very rightly you have said the way you say that the stamp is made to take iron and folic acid कैसे लेना है, क्या कॉम्बिनेशन लेना है, कैल्शियम के साथ नहीं लेना, एक और भी स्टैंप लगा देनी चाहिए कि भैया ये आयरन कैट की टैबलेट जो आपको सरकारी क्लिनिक्स में मिलती है उनकी उतने ही इफेक्टिव है जो आप पैसों से बाजार से खरीदते हैं. आई थिंक ये वाली भी बात
Yes,
अगर
ma'am.
हम एक्सरसाइज कर देंगे तो बहुत अच्छा रहेगा. ग्रीन
Yes,
लीफी
ma'am. Sure.
वेजिटेबल्स तो आपने गाना गाना ही जरूर है उनको, वो ग्रीन
Mm-hmm.
लीफी vegetables and proteins के लिए, and a variety of things are very important. So I think we will take one message each, how to see that the hemoglobin will in a developed world will be less than 5%. We will like your inputs on that particular thing. uh, Dr. Taru.
मैम आपकी जो 2 लाइन्स थी ना, दे वर वेरी गुड. ट्रीट एनीमिया फर्स्ट, ट्रीट एनीमिया फास्ट. उसमें 2 लाइन्स और जोड़ ली उन्होंने.
पिक्चर नहीं अच्छी लगी आपको?
बहुत
जी
सुंदर
मैम,
मैम. शेर और
पिक्चर,
चीता. यस.
हाँ.
वो भी बहुत अच्छे थे, है ना.
चीता तो बहुत बढ़िया थी.
2 टी और जोड़ने
नहीं,
में.
बट शेर भी बहुत इम्पोर्टेंट है. 12
हाँ,
से कम सेटल नहीं करना डॉक्टर साहब.
यस.
वो इम्पोर्टेंट है मैम, तभी तो उसकी जैसा चुस्त बन पाएंगे अपन. टिल डिलीवरी एंड टिल लैक्टेशन, ये 2 उसके आगे और टी जोड़ दिए मेरे. तो
आपको लगता है कि जब तक 2047 आ जाएगा तो हम लोग our hemoglobin will less than 5 gram percent, just like any developed countries?
यस मैम. वो पैशन रखेंगे तो अचीव कर पाएंगे मैम. डेफिनेटली.
मैम
Lina, you have an army background. You have an army background. How you see it?
So, ma'am, I think the situation is the same everywhere. While you'll find the men having a very good hemoglobin, you find women are lagging behind. Whether it's in the general public, whether it's in a corporate setup, whether it's in the armed forces. So actually, we have to really push this. I think if we want to achieve a less than 5% by 2047, we really have to put in, and I think as gynecologists, we have a huge responsibility, because like you said, a anemic mother produces an anemic baby, an anemic neonate grows up and she becomes adolescent. So this entire generation just carries on the anemia. So to break the cycle, we really have to push it really hard. We really have to.
I just wish to tell you, I think I'm in the public forum at this time. I saw a picture, Mardani. I'm telling you, the way the heroine walks and talks, and the movement. You find that many men will have inferiority complex looking at her. So that kind of thing is there. You have to become like this heroine of thing. Anything is possible. It should be ingrained right in her childhood itself that uska hemoglobin 12 gram percent hona chahiye, and then she can sky is the limit for her. So I feel I'm very confident about it, that it should be ingrained in a child. And you also said they are doing a good work as far as Tirath Ram and other hospital neighboring hospitals, Delhi to close to Delhi University are doing it. They are making them to know their numbers. Why hemoglobin of 12 is important, why the BP of 120 by 80, 130 by 80 से ज्यादा नहीं होना चाहिए. अब अगर आप एंटी हाइपरटेंसिव भी लेते हैं, शुगर्स भी आपकी हर टाइम 120 के अराउंड रहनी चाहिए. सो आई थिंक नोइंग योर नंबर्स इज आल्सो वेरी वेरी इंपॉर्टेंट, एंड यू हैव टू टेल देम दैट आपको भी अगर अब्दुल कलाम की जैसी आईक्यू चाहिए और आपको कॉर्पोरेट में जाकर बैठना है तो आपका हीमोग्लोबिन 12 ग्राम परसेंट होना चाहिए. आप 13 भी कर सकते हो, 14 भी कर सकते हो. अगर आपके बराबर वाले कंट्रीज में बांग्लादेश में 13 और 14 हो सकता तो हमारे यहाँ क्यों नहीं हो सकता? फिर वही कहेंगे कि जी हम वो तो मीट खाते हैं, हम लोग मीट नहीं खाते. ऐसा नहीं है. आई हैव सीन, आई कम फ्रॉम प्योर वेजिटेरियन फैमिलीज. I find the ladies, elder ladies in the house have a hemoglobin of 13, 14. It's a great pride, anemia is not common in vegetarians. So I think, I would like to have comments from you, Dr. Makhija.
Ma'am, I would like to say complete treatment, pre-pregnancy, pregnancy, postpartum, and even beyond that, because we should not ignore the perimenopausal and the menopausal women. We are all part of it, not only pregnancy.
Ma'am, the anemia is around 50%, but if you go to the senior citizen, it is something like 65 to 70%, and something has to be taken because उनका खाना कम हो जाता है. तो खाना कम हो जाए,
Hmm.
सप्लीमेंटेशन वो लेना नहीं चाहती.
Yes.
सप्लीमेंटेशन,
Yes.
एक बात बिल्कुल मैं मैसेज क्लियर है. अगर आपका हीमोग्लोबिन 10 है और आप कितनी भी बढ़िया डाइट कर लो, आपका 10 से 11 नहीं होगा. आपका 10 से 9 नहीं जाएगा, पर 10 से 11 भी नहीं होगा टिल द टाइम यू टेक सप्लीमेंटेशन. आयरन, फोलिक एसिड तो लेना ही पड़ेगा. डीवर्म समय समय पे आपको करना ही पड़ेगा. सो आई थिंक यू नो दैट सप्लीमेंटेशन नीड टू बी एम्फसाइज्ड टू देम. डॉक्टर दीप्ति, फाइनली फ्रॉम यू, वाइंड
जी
अप.
मैम. So that was a wonderful discussion. We have a lot of carry home messages as obstetricians. And let me tell you, friends, we are not just obstetricians, we are also care leaders. And our role is very clear. Like I just mentioned about हमारे पास policy है, हमारे पास power है. We have to transfer these policies into practice to move from coverage to correction of anemia and from just not simple guidelines. बहुत बार guidelines पढ़ लिए, बहुत कुछ कर लिया, बात कर ली, बट उसका ग्राउंड लेवल पे हम लोग एज केयर गिवर्स क्या इम्पैक्ट कर सकते हैं. एंड दैट इज हीमोग्लोबिन ऑफ 12 in every trimester and postpartum, and this is non-negotiable. And we have to be very, very, what shall I say the word, like the tiger and the cheetah, aggressive in our
Uh-huh.
approach management and correction of hemoglobin levels.
Doctor, my challenge to you, Dr. Deepti Nav, you are chairman of the Adolescent Health Committee as far Delhi is concerned. Please ask every gynecologist to spend little money, which will be, I will say, not more than 250 to 300 rupees, to put inside the principal's room, you know, or a big hall which is there, that your hemoglobin of a girl should not be less than 12 gram percent and a boys should not be less than 13 gram percent. So they see day in, day out, and, you know, then, you know, they will see to it that their hemoglobin becomes that. So uske koi ek visual impression must go with them that इनका hemoglobin 12 से कम नहीं होना चाहिए. और एक लाइन और भी होनी चाहिए, we aim at less than 5% hemoglobin. So you must we give you know, prizes to schools who are anemia free. We give prizes to colleges which are anemia free. Something of this particular kind you start, and as far as the awards and the rewards are concerned, we will see to it that we give. You take this particular challenge.
Surely, ma'am. We'll do so. Yes.
Any last minute suggestion by anybody?
Ma'am, actually, not only females, Dr. Leena pointed out that males also are dropping out in their hemoglobins these days. Maybe because of the pattern of eating habits outside and fast food. ये pattern जो food का change हो गया है, and the people are working, they don't cook their food, फिर बाहर से खरीद के because they don't have time.
बड़ा हमें नेगेटिविटी से पॉजिटिव की तरफ जाना है. हमको ये कहना आपको ये करना है बस.
तो ये रीजंस हो सकते हैं. तो वी हैव टू एक्सप्लेन टू देम कि देखो इन सब से हमको छुटकारा लेना होगा, हमको अपनी हेल्थ पे ध्यान देना होगा. तो ये सब मत सोचो कि मैं नहीं कर सकता हूँ, यू कैन डू इट. तो सबको ये है थोड़ा सा टाइम निकाल के हमको एक्सप्लेन होगा.
Little extra time for every pregnant patient. Counseling.
Last minute, Leena and Dr. Mikhija.
ये जैसे डॉक्टर तरु just mentioned, what is the point of the wealth, what is the point of being top in whatever they are achieving if their health doesn't keep pace with their life. So this is what we can tell them when we talk about fast foods and, you know, cutting short of food. So we can tell them what is the point. And I think people have understood now that if they want to keep their health at a premium, then only they can achieve what they want to do. So I think we have to talk a little positive to tell them that जो तुम कर रहे हो तुम कर सकोगे अगर you know, one of the aspects is your hemoglobin being 12 grams.
Dr. Nisha?
Ma'am, and I think as Dr. Taru has said, boys, we should involve boys also. Somehow boys are being neglected, I think, because we as gynecologists really feel like taking care of our girls. But boys, I think, कौन सा डिपार्टमेंट ध्यान रखता है उनका? कोई भी
अरे मैडम बॉयज को तो पूरा हिंदुस्तान के टेक केयर करता है डॉक्टर साहब.
मुझे ऐसा लगता है कि
yes I fully agree madam. Wherever there is, yes, there's so much of division. लड़की को कम खाना देंगे. They will not give all the fruits
Our
and
focus is
vegetables.
girls, girls
No,
and
our
girls,
focus.
girls and girls.
लास्ट में
Girls.
मिलता है फीमेल्स को.
And they must see Mardani and
Yes.
become like, no, Madam Rani Mukherjee. Why? She was solid. Chali. Thank you very much, Dr. Deepti. Thank you very much,
Thank you,
all of
ma'am.
you.
Thank you so
Wonderful.
much. Thanks so
Thank
much.
Thank you,
you.
ma'am.
Thank you.
Thank you so much, ma'am. Thank you. Thank you.
Thank you.
Faraz, thank you.